So welcome. My name is Trisha Blake, and I am the track chair for the Collaboration, Training, and Education track. I am very excited to introduce our next session, which is Impacting Global Health with an XR Model of Medical Training. We have speakers Jared Mermey from Gig XR, as well as Deborah Lee from the University of Michigan. Please join me in giving them a warm welcome to this stage. Thank you.
Hello, everybody. Thank you. We're here to talk a little bit about what happens when you remove the constraints of time and space on teaching, training, and simulation in the healthcare space. And very importantly, everything we're going to talk to you about today is already in use. It's already in practice. Nothing here is in the future tense. Nothing here is a hypothesis. My name is Jared Mermey. I'm the CEO at Gig XR. We have a platform that delivers a wide catalog of teaching and training applications in mixed reality. And I'm joined by Deb Lee from the University of Michigan. As you can see, she has way more titles than I do. Therefore, she is the healthcare professional. Deb, can you tell everybody a little bit about yourself?
Yes, no, I'd be happy to. Thank you for joining us today. And I am a clinical assistant professor at University of Michigan School of Nursing, and I am the director of the Simulation Center at the School of Nursing as well. Certified healthcare simulation educator, and then I work in the ICU, work as a nurse practitioner with patients quite a bit every month, actually, part-time. So
you're going to hear us use the word simulation often today. Simulation is incredible demand. Exhibit A is the frequent flyer miles that Deb racks up. Deb, can you tell everybody where you've been?
Yeah.
And why are people flying you around the world to teach them about simulation?
Absolutely. So currently we have this massive healthcare shortage for nursing and for medicine. And so we're trying to upscale the faculty that teach in simulation. And so I've been all over the UK. I've been through France. I spent a month in Thailand working with their with the agencies there. And so it's been quite a fun ride, but.
And who are you engaging with when you go around the world?
So mostly medical schools, nursing schools that are doing simulation, and then also with different agencies. So NHS, I was able to meet actually the Prime Minister for Thailand and for Malaysia. So, and after I leave here, I will head to Barbados, where I meet with the Prime Minister there. So
conventional simulation in the analog is often done with simulated patients, which are actors, or different degrees of fidelity of mannequins and task trainers. Deb, can you tell us about traditional simulations and some of its benefits?
Yeah, so the traditional simulation is using high fidelity mannequins, which cost anywhere from $20,000 to several hundred thousands of dollars. And we want to mimic real life correctly and be as authentic as we can. So we are teaching the faculty how to use these complex mannequins. We also use task trainers to teach procedures, bedside procedures, any surgery that's going on. And then we also use actors. We have a phenomenal cadre of actors that come through the U of M theater department, and we have them mimic any behavior that we want to train the students on. So we have a lot of fun with it.
Cool. And what is the benefit of mimicking, to use your word, right?
So you really want to train up students to deal with low frequency but very high risk situations. And can they detect a deteriorating patient? How quickly can they do that? And the more often I put them into situations, they'll detect things quicker. So we're trying to really upscale the whole workforce by showing them situations they might not see for 5 years. But once they see it, they can realize what's going on.
So simulation is a really, really great technique in the analog, but it has the same limitations of many things in the analog. For us to share a simulation, we have to be in the same place at the same time, in very expensive buildings, using very expensive equipment, trained by people who are co-located with us, who therefore can only train so many people at once. So when you think about that, the impact is that learners who get the benefits of great simulation tend to be in developed nations, tend to be in big urban centers, tend to be at universities, and research institutions who can afford all this. And this is all happening while there's a massive shortage in nurses and training staff. Deb, can you talk a little bit about what you're seeing in that shortage and how that impacts you?
So unfortunately, we know we're 1 million nurses short, even here in the US right now. We had 91,000 qualified applicants that could go into nursing schools last year, and we couldn't get them spots. So, and I looked last week, we had 2,800 open faculty positions for schools of nursing throughout the US. So we know there's a big issue here, and we really need to try to figure out how do we train more healthcare providers with less faculty.
That's exactly right. So I love this image. I think in one picture, it shows the limitations of today's simulations, even though it's very beneficial if you get to do it. You've got a learner in there who's probably spending tens of thousands of dollars on tuition, speaking to a geriatric mannequin that probably costs $20,000 or $30,000. And that voice of the mannequin, when the learner speaks to the mannequin, is portrayed by a human being on the other side of a one-way mirror speaking through a loudspeaker, almost as the voice of God, right? So you can see the mental gymnastics we're going through, yet the benefits we all know we get for doing said gymnastics. Which is why one of the reasons, as a technologist, we look at simulation and say, hey, it should go immersive. There are many benefits of immersive that allow us to get scale and all the benefits of simulation while maintaining all of the good things as well. Deb, can you tell us a little bit about what you've done with immersive?
Yeah, so actually because of COVID, because everything got shut down, we quickly upscaled, right, using the immersive technologies. I do think that XR and actually VR is great for doing some soft skills training and doing, a fire in the OR. We've done that many times. Or requesting organs from a family who has a brain death situation. So, but really where we're seeing the huge growth is within mixed reality and augmented reality. So I oftentimes, throughout our curriculum, I have to teach central line, lumbar puncture, all of these different procedures that all involve sutures, scalpels, needles. So I really don't want them in VR, right? I want the muscle memory, and I want them doing the actual procedure.
So if you all remember what all of our respective mothers probably taught us when we were very young was, don't run around with scissors, right? Don't be scared. If you run around with scissors, run around with sharp things, that might be a problem. We think the same thing when it comes to teaching and training. And one of the reasons why we're very bullish on mixed reality is you can develop procedures where you can still use sharp objects while teaching and training. Deb, can you tell us a little bit about the procedures you've developed?
So we've actually spent the last 3 years now developing at least 15 procedures that is throughout our curriculum at the School of Nursing. It's now at the medical school. And we just received a $100,000 award for developing extracorporeal membrane life support, or ECMO, in actually the mixed reality. So during COVID, we had hundreds of thousands of people die that could have survived had they had the access and trained providers to take care of ECMO. And so we're able to upscale, and by doing all of these procedures in areas that don't typically take care of ECMO patients. So I'm going to give you an example. This is actually a little bit bucolic. However, this is where we're going. And hopefully this will play. Maybe not. Didn't download right. Okay. So this is, unfortunately, what we're doing is task trainers that have the overlay on, here we go. If we can click play, that would be great. So basically what I'm doing is I'm showing the anatomy on top of task trainers, and then I can use the holograms to tell them exactly where to clean, exactly what to pick up. I can teach them ultrasound training by using videos and pictures while they're actually doing the procedure on a mannequin. So the students absolutely love this because they can come down any time of day. They come down frequently, actually, compared to traditional training. And I think the students were doing at least 5 of these procedures before they would go test, whereas traditional training, they'll do it once or twice and then they'll try to go test out. So that gives you an example, and now we're creating it on a platform, on a Unity platform that is accessible and we can share across the globe.
So the question whenever new technologies are adopted is always, well, does it work? Right? It looks really cool. It looks really fun, but does it work?
Yeah.
Deb, I think you're finding that it does.
It does, and our dean was adamant about prove to me that this is better. And so I had to do some studies, but we really had really high acceptability scores. The students loved it with engagement. We reduced our procedural time a little bit, not statistically significant, but a little bit. And we reduced our faculty effort by 75%. So that was huge. The university all of a sudden was now ready to listen. And we had 100% competency pass rate, whether they were trained in the traditional environment or if they were trained in mixed reality.
Yeah, I want to double click here on the faculty effort. We started at the top of this by saying we're removing the constraints of time and space. This is really on the time dimension here. We have a shortage of educators right now, yet huge demand of people who want to get these positions. They want to become nurses. So if the bottleneck is the demands on educators, if we can make them that much more effective, where someone like Deb can share her knowledge without having to be there because she's now training her learners asynchronously, then that's a massive win for everybody, particularly when we can prove that it's already non-inferior, which we've done. We have the data that shows that. I think you have some more research that's coming out, Deb, as well.
Yeah, so then we actually looked across, all institutions and said, who's really looked at this? Did a systematic review, included 17 randomized controlled trials, 6 comparative studies, and then 7 systematic reviews as well. And we were able to show that XR actually improves surgical skills, and they're much more accurate as proceduralists because they know exactly where to cut, they know exactly how far to cut. So we were really impressed with that. Some variable effect on time, and obviously no effect on knowledge, because whether I'm teaching you traditional or asynchronous, you get the same knowledge level. So we're super excited about having better proceduralists.
So we're excited to share that Michigan Medicine, Deb and her colleagues are working with GigXR on a series of clinical simulations that will live inside of our application called Hollow Scenarios. It's one of the several applications delivered by our platform. These are full clinical simulations with holographic patients and holographic equipment, where learners and their educators together can collaborate, diagnose the patient, decide what interventions to take, and if they do the right things fast enough, then the patient gets better. If they don't, the patient gets worse. Luckily, it's only a holographic patient, right?
Right, they can make mistakes.
Exactly, which is the whole purpose of simulation. Deb, maybe can you share a little bit why you're excited about this project?
Yeah, so we've created 3 neuro scenarios. One is hypoglycemia, which is important. If somebody's hypoglycemic, they need to get some sugar and need to be fixed. Stroke, which is a very time-limited intervention. I have 3 hours to get them the correct treatment. So we want to make sure that the staff and providers caring for them know it's a stroke. And then also meningitis. So we've created these three hollow scenarios so that people can train and get. One of the missions of U of M is 1, to educate, and 2 is to share best practices. And I feel like this has been the perfect marriage between being able to educate globally and also share best practices out of Michigan.
And that democratization of knowledge is what our platform is about. Many applications that range from standardized patients to full clinical simulations, pathophysiology deep dives on the lung, heart, kidney, and brain respectively, 3D cadavers, and I'm excited to share that DICOM Library XR will come on here to have a library of CT scans and MRIs as 3D. Again, we said at the top of this is all being used today. We're not speaking in the future tense. This is being used by well over 70 nursing and medical schools around the world, which is really, really exciting to share. And what I want to give everybody a taste of is what one of these clinical simulations can look like. What does it look like when you remove the dimension of space from training?
Right, so Aniket, here we are in the Cambridge University augmented reality simulator. So we've got a scenario lined up for you today. We're joined by colleagues from Northwest Permanente in Portland, Oregon. We've got Trish Ramos, who's the director of simulation there. Hi, Trish. And we're also joined by Steve McIver, who is an EMT and GigXR employee, who's going to help us out with the scenario as well. And they're going to be joining virtually. And we've got Ruby, who's a Cambridge University PhD student and also a doctor and facilitator at the Simulation Centre.
So I can see that the patient's quite breathless at the moment. and she's sounds like she's wheezing, so we'd like to measure her oxygen. Ruby, if you could help me put an oxygen probe on.
That's it, so we can just place that on her finger. So we can see they've come up as 95% there.
Okay, to start off with, I think I'm going to choose a non-rebreathe. Okay, to start off with, I think I'm going to choose a non-rebreathe. She's wheezing, she's using a lot of her accessory muscles, and she seems to be in kind of an obstructive picture at the moment, so I'm worried, and I'd like to carry on my assessment and listen to her chest, if that's okay. Okay. Yeah, I can hear wheezing on both sides of the lung.
What do you hear, Stephen?
Okay.
So what we just saw there is the head of simulation at Cambridge University with the head of simulation for Northwest Permanente teaching and training a series of learners who are not co-located. They're in fact at 3 different locations, 6,000 miles apart. The fact that now we could come together and have that degree of collaboration in the metaverse is what allows for scale to happen. So we shared before with Deb's procedures how time is no longer a constraint. Now you can see how space is no longer a constraint. We also said we're really long on mixed reality. Well, I think the reason why was also shown in this video. For our co-located learners, I actually see the people with whom I'm training with. They're not represented by avatars. The avatars, these little white Michelin men kind of floating looking heads, those are learners who are in different locations. So when I can actually see the people who are co-located with me, and I can move around freely, I can not be fearful that I might bump into a wall or bump into my co-learner. My full cognitive load can go towards what I'm actually learning. Therefore, I'm going to enjoy it, I'm going to retain it, and I'm going to come out better. And we're seeing that in the data, right? Our learners are leaving way more confident in what they're learning. Our learners are enjoying what they're learning. I have no idea who that 18th person was. All right, let me just say that out loud to everybody. And very importantly, particularly for healthcare providers, we're reducing the cost of teaching and training programs. So our hospital customers are sharing that they've reduced the amount of shadow time, for example, that a graduate nurse needs to follow a registered nurse in half. Why is that? They're no longer waiting for real human beings to walk into the emergency room with whatever mix of issues that they need to wait for. They're spawning patients like that, right? And they're getting their teaching and training done on demand. That's a really powerful combination. So what is that going to mean when we can now teach and train and we don't actually have to physically go places? Well, Deb, I'm sorry. The frequent flyer miles aren't going to be so good. But more importantly, we're going to democratize the knowledge that people like Deb have. Deb, I know you've got some projects where you're already seeing folks over in the UK, for example, using your procedures. Can you just share a little bit about the impact that you see this having?
Yeah, so we actually were contacted by NHS, and they purchased 100 HoloLenses and wanted to ship them around the UK to train nursing homes, on how to put in sterile caths, and they wanted to use it for the medical schools on how to do central lines and lumbar punctures. So the procedures that we've developed are now getting transformed into use throughout the UK. So we're very, very excited about that.
Yeah, and we see similar things too. So for example, teaching folks how to do C-sections or birthing complications in places like sub-Saharan Africa. Right now, that teaching and training is not getting done as well as we all would like. One of our partners is very exciting to do that using this technology, because by just pulling out the phone out of their pocket, and we all have phones, they'll now be able to do so in a much more immersive way, right? Such that teaching and training is retained and we get the outcomes we want. Because if we get good outcomes, if we get better healthcare professionals who are learning more efficiently, then we get the most important thing, which is better outcomes for our patients.
Yes, ultimately. And I think COVID has definitely changed the quality temporarily, but it's a struggle. You know, the nurses that graduated during COVID and even the residents and physicians that graduated during COVID didn't get to see as much because it just was not happening. We weren't having elective surgeries. So yeah, we were really focused on improving patient outcomes.
So COVID was very much the impetus, right? Learners were not getting their simulation hours. They were at risk of not graduating, right? We all figured out we all need to perform that simulation in a way that scales better, in a way that we all don't need to be in the same place and time. Enough time has now lapsed where not only have we implemented these new technologies, but we're getting the really exciting data to prove their efficiency. Deb, thank you for sharing what you're doing at Michigan.
Yeah,
we're excited to share what we're doing here at GigXR. And I think we have a few minutes for some questions if folks have any.
Awesome.
Right on time, right on time. So please, everybody, give a round of applause to Jared and Deborah for sharing their work and insights and the best practices on the XR model of medical training. We will have a few minutes for some questions, so I'll open it up to the floor. I see in the back, if I can bring the mic to you, or you can project.
I can just yell. Thanks very much for the presentation. I had a couple of questions. First one, can you describe kind of the outlay for onboarding the learners onto the system, like the impact and how you go about doing it just on the new modality?
Yeah.
The other thing that you mentioned, this piece about like spatial awareness when it comes to procedures.
Right.
Like, do you think that there's like a benefit to spatial awareness beyond like the actual procedure more broadly in medical education when it comes to AR, anatomy, pathophysiology, those types of things?
Sure.
Sorry, two kind of different things.
Yeah, no, so it does take a little bit of time. Our graduate students have not ever done AR for the most part, or mixed reality. So we spend about 15 to 20 minutes with them going through some steps that get them comfortable with the headset, with doing their, with their hand gestures and knowing how to advance. So that it definitely does take time. But as they get through the semester and then in their 2-year program, we're seeing that they're now getting more and more and more comfortable with the headsets. So the dental school just taught all of their procedures actually into the dental students, and they did the same onboarding, and they had really good results with that. So, and then as far as time and space for using the headset in other areas, I think situational awareness, when I'm working and I get called to the OB unit because I have a mother that's not doing well, I think that would be a situation where I want to prepare the students how to have situational awareness of what's going on and how to control that.
Yeah, and if I may just piggyback that, not directly answer your question, I would also recommend don't forget the time that it might take to get the educators themselves comfortable with this technology too. We see that of our customer base who've adopted this, the ones who've taken the time and invested in that are the ones who are seeing tremendous success. Oftentimes the learners, the students, they pick up on it like this, right? It's the educators that we have to invest in as well.
Thank you for that question. One question. We have a minute and 30 seconds left before the next session will get ready to start. Go ahead.
No, you spoke about, you alluded at one point to running with scissors, and then you talked about kind of the scale and listed some of the procedures you had. They were all a lot of physical things, like lumbar puncture and these types of things. How do you achieve that scale where you have these physical components and you're trying to distribute them for people to do self-paced training kind of thing? So what's the...
So it's really around having an open lab. So we have a huge room that's set up with all the different task trainers. Students come down, they go ahead and put their headsets on. There's a whole menu of what they want to work on. They can click on it, and then they can start into whatever task trainer it is that they want to do. So what we are finding is if the students were in clinic and had trouble starting an IV, then they actually want to come down after their shift and go through the steps again to make sure, like, what did I mess up? And so it's open 24 hours a day, open to them when they want to learn. So
we're also building optionality into our user experiences where you can combine the digital with the physical, and when you don't have the physical available to you, have a completely digital experience, still augmented and mixed because we think there's benefits to that, but ensuring that the distribution of the physical equipment doesn't become a constraint for scale. It's a great question.
Thank you very much. We will not be able to take any more questions. I do apologize. However, I'm sure that Deborah and Jared might be gracious enough to take questions outside since the next session will be up, and I'm at 3, 2, 1. Thank you very much, everybody.
Thank you.